brought to you by the Dao Health.
This is Delve, a podcast that endeavours to enlighten and support you in understanding and transforming your own health.
Hello, my name is Elizabeth Cullen and my co-hosts are Clarice Berry and Molly Burton. And together we will be drawing on the Dao Health's signature and unique integrative approach to traditional Chinese medicine.
So take a seat at our table, grab a tea, and let's dive deep into the enduring legacy and evolution of medical practices over time.
This episode of Delve is proudly brought to you by City Fertility. City Fertility is one of Australia's leading IVF and fertility providers. With over 18 clinics, they offer services from IVF treatment and egg freezing to Australia's largest range of donor sperm. City Fertility can help you grow your family. Thank you so much to City Fertility for making this episode of Delve possible. Hello and welcome back to Delve. My name is Elizabeth Cullen and I am joined with my lovely co-hosts Clarice Berry and Molly Burton. Today's episode has a trigger warning. This episode contains open conversation about miscarriage and pregnancy loss that some listeners may find emotionally challenging or distressing. Please listen with care and take a break if needed. You are not alone. If you or someone you know needs support, help is available through accessible services such as Pink Elephant Support Network, Gidget Foundation, Panda Hotline, and we'll include these links in this episode's show notes. Now, I'm going to get straight into it today, ladies, with one of our questions that we asked our community on the poll, and that was, do you think there's enough public awareness for individuals who experience miscarriage? Now, 97% of our listeners and our community said no. Yeah. So I think that highlights how important this episode is, and I'm hoping that we're going to be able to provide more support to be able to navigate this difficult time. And we're going to have Dr Devora Lieberman on. So I think to be able to hear from her and to get her insight as well will be really beneficial. Okay, so today in our Dynasty segment, we're unpacking the history of miscarriage, how it's been deeply entwined with medicine, religion, law, and culture, and how it's understood, treated, and experienced, which continues to evolve to where we are today. Now, everybody, strap yourselves in because this is quite a confronting dynasty of how miscarriage has been managed and how women have been treated for thousands of years. So, ancient practices and beliefs. So let's start with these. Miscarriage was often explained through supernatural beliefs, curses, spirits, or divine punishment. In early Egyptian and Babylonian texts, we find remedies for miscarriage and infertility are evident, though mixed with magical thinking. By the 5th century BCE, Molly mentioned this in another episode, but Hippocrates wrote about miscarriage recommending rest, though he misunderstood anatomy, believing the womb could wander the body and that this could be a cause of miscarriage. If we jump forward to the early modern period, to the 1500s and 1600s, early modern medical literature described miscarriage as an especially dangerous process for women's health, with Jennifer Evans' journal article from 2023 describing in early modern England that miscarriage will bringeth them into dangerous peril. A 1666 text called Women's Friend described it as the bringing forth of an unripe child. Recipe books, diary entries, and personal correspondence show that women often endured significant pain and complications, including retention of the fetus and placenta, fevers, hemorrhaging, headaches, and fertility issues. Miscarriage care at this time reflected not just medical limits, but deeply gendered expectations, with women being mainly cared for by midwives and female healers in the home, with the recipe books mainly attributed to female authors. The treatment focus on prescriptions was that they was seen as necessary to help cleanse the woman and purge to avoid danger, manage symptoms associated with the miscarriage, and to support the woman to regain her strength. During this period, the often associated illness and physical distress to the body were often spoken about as much as the emotional and spiritual factors. Fast forward to the 19th century, miscarriage was commonly understood as a natural event, sometimes seen as a necessary correction or a space of freedom within the societal pressure for women's lives to revolve around childbearing. In a world where women had less control over their own fertility, some experienced grief and viewed it as failure, and others didn't. They actually saw it as a relief from reproduction.
Wow, isn't that interesting?
Yeah. The term miscarriage wasn't consistently used. Words like spontaneous abortion or simply a cold were common, and grief wasn't always acknowledged. It's very confusing with the medical literature at this time because the words abortion and miscarriage were interchanged.
Right. Oh.
So to fully get an accurate experience of what these women went through is still a little bit unknown. Although the response to a miscarriage was varied, it was still seen as a private and difficult experience to women with a lack of support. Interestingly, the medical management, including the introduction of a dilation and curettage, D&C as we know, was a procedure to clear the uterus, which became available for treating miscarriage in the early 19th century. In the 20th century, we begin to see society's reaction to miscarriage changing and the understanding of miscarriage, evolving significantly. From the beginning of the century, viewing miscarriage as, trigger warning, fetal wastage, to recognising miscarriage as a devastating loss of a baby and providing accessibility of emotional support for the mother. Again, at the beginning of the 20th century, terms such as spontaneous abortion were used, and there was a lack of consensus on when to use the term miscarriage or abortion with women. Medical understanding remained unlimited, with miscarriage often blamed on stress, physical exertion, or maternal weakness. Minimal focus was on actual causes such as chromosomal abnormalities, and psychological support was also not readily available. By the 1940s to 1960s, with the rise of hospital births and improved maternal care after World War II, more miscarriages were managed in clinical settings. The development of the Rh factor testing and better infection control helped preventable pregnancy losses. However, miscarriage remained viewed as a private tragedy rather than a public health issue, and women received minimal information or support after loss. Emotional pain was often dismissed or associated with pathology, such as hysteria or nervous breakdown.
Horrible.
Awful. In the 1960s, the use of the word miscarriage in Britain instead of spontaneous abortion occurred after changes in legislation with more focus on communicating responsibly to women about pregnancy loss. Additionally, in the 1960s, the oral contraceptive pill became readily available. Not only did the birth control movement provide women control over their own fertility to prevent unwanted pregnancy, but also from the burdens associated with miscarriage. The women's health movement of the 1970s and 80s helped break the silence, and support groups like SANS emerged. Ultrasound became routine in maternity clinics in developed countries, making earlier diagnosis of miscarriage possible, but possibly this also created new kinds of emotional trauma through early attachment that weren't supported.
Yeah.
Now, we start to see a shift in perspectives by the end of the 20th century. Miscarriage care had begun to shift towards a more empathetic and informed approach, with changing medical terminology and increasing awareness of the psychological impact on women. Research began to highlight the mental health impacts of miscarriage, that a woman and their partner saw a miscarriage as a loss of a child rather than a medical incident. In the 21st century, miscarriage management primarily involves three approaches: expectant, medical, and surgical, although when experiencing a miscarriage and the possible emotional and mental health repercussions remains difficult to navigate. The conversation around miscarriage is slowly changing, with Dr. Jessica Zucker creating and launching the hashtag I Had a Miscarriage campaign with her first New York Times piece in 2014, with the aim of addressing the antiquated cultural silence stigma, and shame surrounding pregnancy and infant loss. This has sparked the conversation around the world for women to know they are not alone and are 1 in 4. So where are we now? So we're in 2025, and this conversation is more urgent than ever, not only in Australia but across the world. We know that there still is religious, cultural and lawful implications, and progress is only getting so far. A recent poll we ran in May found that 98% of respondents felt that there's still not enough medical guidance or support when facing miscarriages. And this is reflected by now, only for the first time in 2025, that RANZCOG has developed Australia's first national miscarriage care guidelines for young Australians aged 18 to 44 across the country. Now, this is a really positive change, but also this highlights the mismanagement of miscarriage previous to 2025 in many ways. These guidelines provide best practice for miscarriage, recurrent miscarriage, and ectopic pregnancy up to 14 weeks. This announcement included that recurrent miscarriages are now defined as 2 and over losses rather than 3 and over losses like before, and they don't need to be consecutive. Now, why this is so important is this means that women will be able to access investigation and support much earlier and receive patient-centred care with compassion. Yeah. So I'm really looking forward to having Dr. Devora Lieberman on today so that we can hear her insights into how miscarriages are managed. Okay, so for today's deep dive, I have the absolute pleasure to introduce you to our guest, Dr. Devora Lieberman. Dr. Devora is a highly experienced IVF specialist and gynaecologist known for her progressive, evidence-based and compassionate approach to patient care. Originally from New York, she obtained her medical degree in the US, completed residency training in Washington, D.C., and obtained a Master of Public Health from Harvard University before relocating to Sydney in 1997. With over 25 years in fertility and women's health, Dr. Lieberman became Medical Director at City Fertility Clinic in 2019, after 16 years at gynae. She has held key leadership roles, including President of Family Planning New South Wales and Director of the Fertility Society of Australia, and served as a visiting medical officer at Royal North Shore Hospital's Menopause Clinic for 17 years. Dr. Lieberman is also an author and speaker, co-writing Empowered Fertility to help individuals navigate the psychological, emotional, physical, and social challenges that arise with infertility and IVF treatment. At City Fertility, she leads a dedicated team providing personalised care in a state-of-the-art IVF facility that offers a full range of assisted conception services. Welcome, Devora. Thank you so much for joining us today.
Thanks, Elizabeth. It's a pleasure to be here virtually.
So to get started, Dr. Devora, when should further investigation commence with miscarriage?
Historically, we've said that recurrent miscarriage is after 3 consecutive losses. More recently, though, and I for a very long time, have thought that women should undertake miscarriage investigations after 2 losses.
Yes, so RANZCOG guidelines is just...
These are RANZCOG guidelines, American guidelines, British guidelines. Yes, all the guidelines have changed. Oh, actually, I take it back. I think the British still say 3. But that's because of the NHS, and the NHS doesn't want to spend any money on investigations.
And was America ahead of us? Did they change their guidlines how long ago?
Yes. Oh, gosh. Years ago, maybe 20 years ago.
Oh, really? So, 20 years ago?
Yes. We Commonwealth people have been a bit slow to catch up. Well, but I think after 2, yes, people should be investigated. And I'll also say that I think, if possible, every miscarriage should be checked for chromosomes, if possible. It's not common to do chromosome checking in a first miscarriage, but I think it is quite important. It can give you a lot of information. If you miscarry and it's chromosomally abnormal, well, that's normal. It means there's nothing wrong with your ability to carry a baby. If it's normal, well, then you might think about doing investigations even sooner than that.
Yeah, being proactive.
Exactly.
Makes such a difference for women and their families. So what advice would you give someone, when experiencing a miscarriage, and where should they go, Devora?
Now, it's quite difficult. Miscarriage care in Australia has been fraught with challenges, making headlines. And there have been some fantastic advocates in this space trying to improve early pregnancy services in public hospitals. And I think they are making strides and things are getting better. In an acute miscarriage with bleeding, my best advice is to avoid an emergency department unless you absolutely have to go. If you're miscarrying, there's nothing that doctors can do to stop it from happening. And you just end up being miserable on a plastic chair in an emergency department, feeling even worse than you already did. So I would say only go to an emergency department if you're having such heavy bleeding, you're soaking a pad an hour, or such severe pain that you need severe pain relief. I think best to see your GP, see your gynecologist, obstetrician, if you have one, and have follow-up as an outpatient.
As an outpatient as well, Devora, I guess we have the EPAS clinics in New South Wales. Do we have them around Australia, or is it just New South Wales?
I know that they are in Queensland and Victoria.
Okay.
I think it's a national movement to try to improve early pregnancy services around the country. And as I say, they are getting better.
Mm. Can a woman directly go to an EPAS clinic, or do they need a referral from their GP?
No, you can self-refer to an EPAS clinic.
Okay.
So just Google your local hospital and get the phone number and give them a call.
I'm surprised from patients in the clinic how many people aren't aware of the EPAS clinics and they think the first step is ED, which is quite concerning.
It is concerning. I think we need to do a better job of alerting people to what services are available.
Absolutely.
I think nobody expects a miscarriage, right?
No. And you don't really even want to allow your mind to go there, right?
No. And it's funny, isn't it? Because people will say, oh, I'm not going to tell my friends and family about my pregnancy until I'm 12 weeks because you're worried about a miscarriage, but then you don't expect a miscarriage. It's a bit incongruous.
Yeah, and then you don't actually have their support at that time when you need it because you're explaining that you were pregnant and now you're going through a miscarriage.
Yes.
So it's a bit of a process there.
Yes.
Yeah. Okay, so next question there, Devora, is what are the reasons why someone would experience a miscarriage?
Almost always when a pregnancy fails, it's about the embryo. There is just about nothing that a woman can do to cause a pregnancy to fail. I think it's really important to know that. And I know when you go and you have your ultrasound and you get I'm so sorry, there's no heartbeat. You go through every minute of every day of that pregnancy thinking, oh, it was the bag of groceries I picked up. It was the argument I had with my partner. There's nothing that you can do. So something like 50 to 75% of miscarriages will be because of chromosomal abnormalities. Having normal chromosomes is a necessary but not sufficient criterion to make a healthy baby. So much has to go right for an embryo to become a baby. I've been doing IVF for over 20 years, and every time I do an embryo transfer, it astounds me that little ball of cells knows how to make a baby with 10 fingers and 10 toes.
Yeah, it's amazing.
Absolute miracle.
It is extraordinary.
Yeah.
So there's a whole lot that can go wrong. I would say in probably 5% of cases will an embryo be both chromosomally and structurally normal.
5%.
Yeah.
Wow. Yeah, such an important message to get across for women, I think, because there is associated guilt with a miscarriage. And to know
much guilt.
So much. And I think for them to know that that's out of their hands and it's out of their control.
Mm-hmm.
Yeah.
That's why I think it's also helpful if you can get chromosome testing.
Yes.
Yes.
It's not an expensive test these days. It's done in a molecular way. It can be billed to Medicare. And I think it just can provide a lot of comfort if it's abnormal.
How would a woman request that, Devora?
Well, it's tricky unless someone's having a curette. But if you're miscarrying at home, it is possible to get a sterile specimen cup.
Okay.
and collect what's passed in that cup. You may not get an answer. There may be contamination, but it's certainly worth trying.
Giving it a go. And would you take that to the GP, or would that need to be straight to a gynae?
You could take that to the GP, and they can send it for molecular testing.
Okay. And is that across the board with GPs? Like, that, would they be open to that?
I can't speak for all GPs.
Yeah.
You'd like to think so.
Yes.
Patients. The other support I will plug is a group called Pink Elephants.
Yes, absolutely. We've mentioned them on the podcast, actually.
Yeah, Pink Elephants. Sam has done an extraordinary job developing this incredible peer support group with good information and resources about miscarriage. It can be such a lonely experience, especially if you haven't shared it with anyone, right? So I think to find similar people who have gone through similar things can help normalize things for you and help you understand that you're not the first person to go through this. And I think that's really quite important.
Yeah. Definitely. Now, Devora, often in clinic there's confusion between a chemical pregnancy and a miscarriage. Would you be able to define what a chemical pregnancy is and how that differs to a miscarriage?
Sure. It sounds like semantics, and I really hate that term, chemical pregnancy.
Yeah.
Technically, we can't call something a miscarriage until we either see a sac on ultrasound or we have a tissue diagnosis. So you pass the sac and we have a tissue diagnosis. Many pregnancies will fail before they even get that far. And the only evidence we have of the pregnancy is biochemical, the positive pregnancy hormone. I don't mean to discount biochemical pregnancies. They are losses and they matter. Having said that, from a prognostic perspective, when you look at your chance of your next pregnancy going to term, based on how many miscarriages you've had, you're actually better off not calling them miscarriages.
Okay.
That they don't count towards that chance of your next pregnancy going to term. Does that make sense?
Yeah, that makes sense.
Yeah.
And so from a proactivity perspective for someone who's experienced a chemical miscarriage, is there anything that they need to do, or are they able?
No, nothing that they need to do. I think, making sure that the pregnancy hormone level goes to 0.
Okay.
Because you can also have low pregnancy hormone levels when a pregnancy is ectopic in the tube. Yes. You want to be sure that that's not the case. Having a biochemical pregnancy tells us a lot of positive things, though, right? It tells us the woman ovulates. It tells us the egg fertilized. It tells us the embryo at least started to implant. It just didn't have what it takes to go the distance.
Absolutely. Now, Devora, we're going to go into our Dear Dao Does segment. Now, this segment is reminiscent of Dear Dolly magazine, and it allows our listeners to anonymously send their burning questions without judgment, and we'll unpack and answer them. So today, Devora, our question that we've received from a listener is, when can I try to conceive after a miscarriage?
Well, back in the olden days before we had ultrasound, the advice was wait 3 months. And that was, I think, to allow your menstrual cycle to reestablish itself, so that your obstetrician would be able to date your pregnancy. Now, with ultrasound, we can date pregnancies much more accurately with the scan than with dates. So I say there's no point in waiting at all. It's more about your headspace and where you're at, and if you're ready to get back on the horse and start all over again.
Yes, definitely. And does that differ depending on what stage of the pregnancy that a woman has miscarried?
I think if it was a second trimester loss or
yes,
very different. I'm talking specifically here about first trimester losses.
First trimester, yeah. In Chinese,
and also if you've had a curette and need to abstain for a couple of weeks, you're probably going to miss out on that first ovulation.
Yes, right. And then so allow a bleed and then come into that next cycle.
Yeah, exactly.
Okay. Well, thank you so much, Dr. Devora, for coming on.
It's a pleasure.
To delve.
Thank you so much for having me.
And thank you for everything you do for our patients and for the community.
Well, thank you for what you do for our patients. Appreciate you.
Thank you.
Thank you, Devora.
So, ending with dessert today, we're going to talk about traditional Chinese medicine and its view of miscarriage. Now, we asked our listeners and our community if they received traditional Chinese medicine for miscarriage support, and 51% said yes, but 49% said no. And I think there is a lack of awareness in our community, especially in Australia. I think not so much in China, but I think in Australia, the knowledge around that traditional Chinese medicine can be used for miscarriage support. Yeah. So to begin with you, Clarice, how does traditional Chinese medicine support a woman going through a miscarriage?
Yeah, so aside from providing like a safe space for women to come in and talk about their experience and really check in with how they're feeling mentally, physically, acupuncture is fantastic at helping that hormonal regulation. We look from a Chinese medicine lens at the body and the uterus as something that we want to keep warm and blood circulation happening too. So when you're coming in post-miscarriage, we see the body in this very cold state, or the uterus being quite cold. So with our acupuncture treatments, we're using another therapy called moxibustion, which is a herb that you can either burn singularly or you can mix that with charcoal, which is a smokeless form, which we use in our clinic. And we do a lot of moxibustion on lower points on the conception vessel, on points like Zhigung, which translates to palace of child. So we're really bringing in a lot more blood flow and warmth into those channel systems to help restore that warmth that has been lost. And then with our acupuncture, and of course, we know that acupuncture is great at regulating the hypothalamic pituitary gland ovarian axis. We're helping those hormones start to find their baseline again. But a lot of it is just holding space.
Definitely.
Yeah.
Absolutely.
And I think as well, there's something else that we highlight in clinic with patients that are undergoing or have been through a miscarriage is like what Clarice said, is supporting the woman and supporting her in that space at the time, but then also thinking about, hey, okay, let's build her back up again. So we can do that with our acupuncture, but then we also use lots of traditional Chinese herbs and particular formulas that will also help warm up the womb, as we describe in Chinese medicine. And this is something that we may prescribe to the individual after this time has happened, so that we can get them back into that balance in terms of their hormones and reproductive health. And then something else that we might highlight is, thinking about our Chinese dietary therapy as well. And this can be an amazing tool if we don't have access to things like acupuncture or traditional Chinese medicine in terms of herbal formulas. You can also use a dietary component at home. So this is, making yourself a really warm chicken soup, for example. This may or may not have Chinese herbs in it, but you can be adding things like red dates in there really to build and nourish the blood, support the kidney essence as we talk in Chinese medicine, and really warm up the body.
And ideally, Molly, when do you like to see a patient post-miscarriage?
I think as soon as they're ready, or whenever they can. We see lots of women in the clinic, of course, and we are with them on their journey. So wherever they may be, whether this is their first miscarriage or maybe subsequent miscarriages, or if they're a new patient to the clinic too, we'll be there to support them. So honestly, whenever the time is right for the patient. And like what Devora said in terms of our Dear Dao Does question today about, when can a patient be open to conceiving, or when can they try again post-miscarriage? And as Devora mentioned, it can be whenever they're ready. So, coming in with our Chinese medicine in terms of acupuncture, we're supporting also their emotional state. So really building them up, and we're having those open conversations. So we'll meet that woman whenever she's ready, whether we're still supporting her just to regulate her hormones and support her heart and her shen, as we describe, or whether she is ready and open to conceiving again, we'll support her cycle and ovulation and potential implantation as well.
Alrighty. Well, thank you so much for sharing your insights today. And thank you to Dr. Devora Lieberman for coming on to our podcast and being able to give us such a knowledgeable insight into miscarriage support and management in Australia. Now, again, please know that you aren't alone. And if you or someone needs support, help is available. We'll put those links there for Pink Elephant Support Network, Gidget Foundation and Panda Hotline into the show notes. Thank you.
Thank you.
Bye.
Thank you for listening to this week's episode of Delve and being a part of our community. Follow @the Dao on Instagram to vote in our polls and stay connected. Ask our team a Dear Dao Does question via the link in our show notes. And for more information and to sign up to our newsletter, visit our website.
The content provided on this podcast is for informational and educational purposes only. It's not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a qualified healthcare professional with any questions you may have regarding a medical condition.
Leaving a review on Delve helps others to find our show and increases awareness for women's health and traditional Chinese medicine. We would love if you can take a moment to like, subscribe, and share. This episode was recorded on Gadigal land. Always was, always will be traditional Aboriginal land.